for Monday, May 11th. We'll turn it over to Danielle Ross to do roll call.
Director Maxwell.
Here.
Secretary Gordon.
Present.
Lieutenant Governor Gay. Present. Treasurer Davis. Present. Commissioner Navarro.
Here.
Secretary Young. Deputy State Court Administrator Ashley Tucker. Jeff Tajner.
Here.
Paul Baumbach.
Present.
Karen Peterson. Bill Overton.
We'll go to agenda item number 2, which is the approval of the April 20th, 2026 SEDC meeting minutes.
Need a motion.
I would entertain a motion to approve. Yes. Motion, and I have a second. Second, Paul. Any discussion on the minutes? Seeing none, can we do a roll call, please?
Director Maxwell.
Yes.
Secretary Gordon.
Yes.
Lieutenant Governor Gay. Yes. Treasurer Davis.
Yes.
Commissioner Navarro.
See.
Secretary Young still absent.
Nope, I'm here. Sorry to be late.
Are you not voting?
No, she said yes.
Deputy State Court Administrator Ashley Tucker still absent. Jeff Tajner.
Yes.
Paul Baumbach.
Yes.
Karen Peterson. Are you still absent? Bill Overton.
Yes. Minutes approved. As you probably all see on the screen behind you or in front of you, you see there's no addition to the SEDC team. So Director Hartos is not here for obvious reasons. So I'm going to turn it over to Kristen to do the director's report.
Morning, everyone. Kristen Barnacle Short from the Statewide Benefits Office. I'm going to start with some RFP updates. The PBM RFP was posted for solicitation on March 25th following the SEBC approval. The intent to submit proposals deadline was April 1st, and we received 12 intent to bids. Proposals were due on Monday, April 27th, and proposals were received from the following 10 vendors: Capital RX, CVS, Express Scripts, Highmark, Blue Cross Blue Shield of Delaware, Lucy RX, Med Impact Healthcare Systems, Optum RX, Rightway Healthcare, Smith RX, and Vivid Clear RX. WTW and the Benefits Office are currently reviewing proposals against the SEBC's approved minimum requirements. The PBM Proposal Evaluation Team, previously known as the Proposal Review Committee, will begin convening in August to review finalist proposals, conduct vendor interviews, score proposals, and develop a recommendation to the committee. On to some benefit updates. Open enrollment first. As a reminder, 2026 spring open enrollment is taking place right now and will end this Friday, May 15th, 2026. Unless a member experiences a qualifying event, open enrollment is the only chance for members to enroll, cancel coverage, or change plans for themselves and their families for benefits administered by the Statewide Benefits Office. This open enrollment period also includes enrollment in the dental and vision plans for Medicare retirees. All eligible employees, retirees, and participating group members are highly encouraged to participate in open enrollment and to verify their benefit selections prior to the May 15th deadline. I also have some legislative updates. Senate Bill 289 was filed on April 21st and makes the following structural changes to the SEBC. First, it makes the director of the Office of Management and Budget a regular voting member instead of the chair. It removes the state treasurer as a member of the committee, makes the Controller General a voting member of the committee, adds a chair of the Delaware Health Care Commission to the committee, and designates the chair of the Delaware Health Care Commission as the chair of the SEBC. It allows appointed members of the SEBC to select designees to attend committee and subcommittee meetings with approval of a designee by the appointing authority. It clarifies that quorum attendance at a subcommittee does not count as a full committee meeting and requires roll call votes for official subcommittee actions. The bill was voted out of the Senate Elections and Government Affairs Committee on May 6th and was placed on the Senate ready list. That is all the updates I have. Unless you have any
So
questions.
that's the only bill that we're tracking right now?
No, we just wanted to call out that bill specifically, and I will have a legislative update email to go out to you all probably next week.
And did we have any engagement from whomever wrote the bill?
Yeah, Senator Townsend reached out to me,
To you?
requested a bill, yes. Mhm.
I didn't get any outreach.
I talked to Colleen on multiple occasions about the bill.
You talked to me about elements of the bill, which were that you would be removed. You did not talk to me about the fact that I would be removed as treasurer.
Okay, well, you recall the conversation differently than I did.
So Brian, were you the intermediary or,
Yes, I was the intermediary,
and
yes.
so you spoke for me?
No, I asked you if you would be okay with coming off the committee, and
No,
you
you
said,
didn't.
I didn't.
No, you did not.
Okay,
Brian, you talked about the fact that you wanted to be off the committee.
Colleen, we can talk about this more, but we definitely had the conversation, because there was more than one committee member that I talked to was willing to come off the committee.
And
And you said you were okay coming off the committee.
who was the other committee member?
I don't need to disclose that.
It's interesting.
What's interesting about it?
So I think we could have another conversation outside of here. My concern is that this won't be my role very soon. So I think it's odd that you would advocate to remove an elected official who represents other people as part of a broader population.
Colleen, I don't know why you don't recall this conversation, because
Right? We can,
sure, we can.
Yeah.
Right. Advocate against the bill then.
I'm sorry,
You can advocate against the bill if you want.
I'm not interested in me personally advocating against the bill. I think that from the perspective of a bill like this being passed, it would have been, it's not your issue, would have been nice for the legislators who are putting it forward to have contacted me and not to have taken whatever your word was, because clearly it was different.
Gotcha. Anybody have any other comments?
Brian just had a question about Dwayne Hill Hoxton.
Yeah.
I like him. We're friends. You know, he already chairs the healthcare commission. He's a surgeon. He's a pretty busy guy. So I was just curious as to why he was chosen. And I don't mean necessarily well, I guess I do mean he specifically, because he also chairs, you know, he's a pretty, again, it's not a knock at him, not disparaging him. I like him. We're friends. I was just curious as to why him.
I would say Dr. Neil has been really engaged in the rural healthcare transformational grants, which are going on in Delaware currently. His background with the Healthcare Commission, I think, fits nicely with, I think my personal view is that that's something that the SDMC as a committee as a whole needs more of. And so I made that recommendation with regards to that.
Thank you.
Nothing else more? All right, we're gonna enter into executive session pursuant to 29 Delaware Code 10004B 6A, discussion of content of documents excluded from the definition of public record pursuant to 29 Delaware Code 10002 O2, and it's regarding dental benefit loss ratios. So entertain a motion to enter executive session. Second. Motion's
Second.
been approved and seconded. All those in favor say aye.
Aye.
Those
Aye.
opposed? Seeing none, well, we're gonna go into executive session. you want to mark yourself present?
Correct.
Ashley,
Ashley Tucker. Yes, correct. Ashley Tucker marking herself present. Thank you.
moving on to agenda item number 6, SEBC Subcommittee.
Dental RFP.
Number 5.
I'm sorry. All right, agenda item number 5, dental benefit request for proposals.
Good afternoon, everyone. Michelle Gass from WTW. I'm here presenting on the dental RFP. And for the contents of this discussion, we're going to focus on the context. So what we're trying to cover there is just giving an update on what's been covered up until today, as well as what we will be covering today. A summary of the SEBC follow-up questions and answers from the April 20th SEBC meeting, next steps, and then there's items in the appendix from prior discussions that were updated. So first here on the context, so during our March 23rd SEBC meeting, WTW presented the dental RFP scope of services, and we also reviewed the high-level RFP objectives. And the SEBC was able to provide initial feedback to ensure we took that into account as we were drafting the RFP for the SEBC's review and approval in the coming months. In preparation for the April 20th SEBC meeting, WTW and the SBO provided that initial draft of the RFP to the committee members for their initial review and feedback. During the April 20th meeting, we presented the information about the employee and pensioner dental survey results, which was conducted in 2021. We reviewed the proposed DPPO high and low plan options, as well as the scoring criteria, and we voted to approve moving forward with the DPPO high and low plan options. So removing that DHMO and moving forward with a DPPO high and low plan, understanding that that low plan would really focus on giving that alternate low cost option that focuses on preventative care, and then a high DPPO high plan option, which allowed for a richer plan design for those employees and members that needed a richer plan option with additional considerations in mind. In preparation for today's discussion, we focused on ensuring the SEBC had their questions answered from the prior meeting, which we'll review at a high level on the coming slide. And then also the dental RFP was provided a week in advance of this meeting so that the SEBC could review that in detail so that we can vote on the approval of the dental RFP today to be posted later this month. So this next slide goes into the detail of some of the follow-ups that were raised during the April 20th SEBC meeting. So the first item is the SEBC voted on the DHMO plan being removed and focusing on a DPPO high and low plan. The reason we wanted to highlight this on the questions and answer follow-ups is that it impacted the RFP draft from when it was sent to the SEBC last time to this time. So what I mean by that is any attachments that reference the DHMO plan or any different plan design information or scoring criteria that refer to the DHMO plan was removed throughout the RFP and updated so that the draft provided to the SEBC in advance of this meeting only included the DPPO low and high plans for your consideration. The next item was around the scoring criteria. So during the last discussion, the SEBC voted to remove the responsiveness category because, as discussed, this did not have a major impact on majority of the RFPs. It was 5 points. We removed that, and that was updated in the scoring criteria on pages 23 and 24, which would have been in the version that the SEBC received in advance of this meeting. The last item here was that an SEBC member asked for further details on the providers that have left Delta Dental and Dominion during FY26 from July 2025 to current. As you'll see from the right-hand side, Dominion has one provider terminated their contract with Dominion National. Their reason was around fees being too low to sustain the business. And then Delta had 165 providers terminated their contract with Delta Dental. They did share that majority of those were out of area and did not impact patients related to the state of Delaware specifically, but they did provide a further breakdown, which you'll see below, regarding the reasons for termination from the Delta providers. Any questions on the follow-ups that were requested for the dental RFP before going into next steps? No? So the next steps here are showing that the SCBC will vote on approval of the dental RFP, which will be later after public comment. And then the RFP will be released on May 28th, 2026, once we've had the approval from the SCBC to do so. Are there any questions on the current status of the dental RFP before it goes to approve later this meeting?
Karen Peterson?
Yes, thanks, Mr. Chairman. Just for the record, I was muted during when you took attendance. I was muted for the first vote, which was the approval of the minutes, and I was entirely blocked from the executive session. So I have no idea what discussion took place, so I'll probably have to go not voting.
Do not believe she was muted. I would suggest
Time stamp when she signed on.
Pardon?
nobody purposefully muted you. I don't know if you were having technical difficulties or not, but we did attempt to get your microphone
But
working.
you did, yeah, you did get it working right after the vote on the executive session. Prior to that, it was, I was not able to activate the mic. But then I was blocked completely from the executive session.
Can we make sure that everyone has the call-in instructions as well? So if there ever is an issue with the technology, an individual can use the phone
It's
to
on
call in.
invite.
That's,
Yeah,
I'm
yeah,
not saying.
but I,
it wasn't.
you know,
I'm
I don't
just
think I could get
asking.
into I don't think I can get into an executive session by phone.
But at least so that we can identify the problem. I just want to make sure that everyone has access to you all during the course of this in case there are any clips, because we do want everyone.
You mean, you want them to have my contact information so they can
Or whoever.
text? Okay.
I think it's helpful for us
Yeah.
because technology is never our friend,
Yeah.
unfortunately.
And I did see that she tried to call me 7 minutes ago. but
So that's
I had
what
my
it
phone
is,
muted.
yeah.
Yeah, I texted Bill at the very beginning when
Bill
I
came
was,
over and did
And I
tell
sent it
us,
every
I'm sorry,
time.
it's Kristen
Okay.
Short, but
so I
sometimes
heard,
it is
I
helpful
I
to
heard, I heard
log off
none of
and
the,
log back in.
I heard none of the executive session at all. So I don't know what happened, but my mic wasn't activated until after the roll call on the minutes, approval of the minutes. So I don't know. I know you're going through some administrative changes there, but I just wanted to make note, whoever's, operating this thing, let them know I'm a member of the SCBC and should be in the executive sessions. Thank you.
Well,
Yes, given the broad discussion topic in the executive session of loss ratios, and as it relates to the upcoming vote on the dental RFP, is it correct that the details of the contracted loss ratio target is something that's done in the contractual phase, not in the submission and criteria, or is it part of the criteria is considered during the criteria?
It's part of the contractual discussion.
So it's post whatever
So
the PRC's out.
in the recommendation that the PRC would make, or the proposal committee at that time, they can say that they would like the SBO to consider that in their contract negotiations.
Okay, is that in the current RFP? Or,
No, I mean, so as an outcome from the RFP, in the process with the PRC, when the committee is making a recommendation to the SCBC,
Yes.
you can put considerations for the contracting. So you could note that in there as an outcome from the voting for the RFP winner, is what I mean.
okay, so I'm gonna share I'm sorry, this is Paul Wambach speaking.
And Michelle Gass from WTW.
I'm gonna suggest that as guidance to the SBO, which is running the PRC for the, I know it's not PRC, whatever, for the dental RFP, that indeed, some guidance regarding the profit loss ratios be mentioned in the future recommendation to the SCBC for approval of their recommendations.
Correct.
Okay.
is there any other discussion on the dental RFP? move on. We'll take a vote on that, so after public comment. Agenda item number 6 now, SEBC subcommittees.
Good morning, Kristen Barnacle Short from the Statewide Benefits Office. Today, I'm going to walk through the proposed update to the SEBC subcommittee structure. The proposed subcommittee structure is designed to align directly with and operationalize the FY26 to FY29 group health insurance plan strategic framework that the SEBC approved at the April 20th meeting. I'm going to keep it high level and focus on the structure, rationale, and next steps, and then welcome your feedback. At a high level, we're recommending 2 key changes. First, that the subcommittee considers striking the current subcommittee resolution for the previous subcommittee structure, which is not currently active. And second, that we establish a new subcommittee structure that is directly aligned with the strategic framework. The proposed subcommittees are the Financial and Vendor Strategy Subcommittee and the Health Outcomes and Data Insights Subcommittee.
Yeah.
The structure is designed to align work directly to the strategic goals, linking directly to goals 1 through 4, assign defined work plans and deliverables, bring actionable recommendations back to this committee, and cover the full scope of the strategic framework. There's a few intentional design elements that I want to highlight. Each subcommittee has clearly defined topic areas tied to specific goals and strategies. And the structure includes specific tasks and reporting deadlines to ensure accountability. And I know that Mr. Bombach and Lieutenant Governor Gay had previously asked about timelines for some of the items that were in the framework. Under the proposal, each subcommittee includes representation across key stakeholder groups, the administration, labor, retirees, elected officials, and judiciary. And then the chair of each subcommittee must be an SEBC voting member. The SEBC would still retain the ability to create additional subcommittees as needed, and joint meetings could be held where topics overlap to ensure alignment. You go to slide 3. So the first one, the Financial and Vendor Strategy Subcommittee.
Before we go to slide 3,
Yeah.
the second to the last burger done. I'm just trying to understand, at least maybe you can articulate for me what appropriate professional qualifications or experience relevant to the duties. What does that constitute? Can you define that for me?
Yeah, I think one of the things that we would recommend is that if a designee is representing you as a subcommittee member, that they share whatever group that you are representing. So if you're a retiree, like perhaps it should be a retiree, but these are all things open for discussion among the SEBC members.
Yeah, I was just curious because it's rather nebulous, and I'm not sure who would meet those standards.
Yeah, we could consider revising that to make it a little bit more clear.
Yeah, I appreciate it.
Based on your whatever feedback you provide.
This is, Kyle Gay, I think maybe if it's the must throwing you off, right? It's like, maybe instead Kristen's reading it as a good faith effort to ensure the person has something to say,
I certainly
right?
support that.
Yeah, so we could language. Okay. All right, slide 3 is the Financial and Vendor Strategy Subcommittee. This subcommittee focuses on the financial sustainability and cost management of the program. Its work primarily aligns with goal 3 of the strategic framework, managing healthcare costs for the program and for members. Key areas of work include benefit design optimization, high cost drug spend management, high cost condition strategies, vendor contracting and performance, member engagement as it relates to avoidable costs, and use of actuarial and demographic insights to better understand cost drivers. You'll see that this subcommittee has defined tasks and in some cases, specific reporting deadlines. So basically this group answers the question, how do we manage costs while maintaining value? Are there any questions on this slide? And I'm gonna, we're not necessarily, any feedback you want to provide today on this is welcome, but we're also gonna ask you to provide feedback by email by a certain date, so we don't have to, go through everything line by line today. All right, next slide. The Health Outcomes and Data Insights Subcommittee. This subcommittee focuses on improving member health and using data to drive better decisions. Its work aligns primarily with goals 1, 2, and 4 of the framework, and key areas include primary and preventive care engagement, population health strategies and targeted outreach, site of care optimization, advancing value-based and alternate payment models, strengthening data analytics capabilities, and then ongoing evaluation of the framework. So this group would basically answer the question, how do we improve outcomes and ensure we're using data effectively? Questions? So next steps, in terms of next steps, I welcome any feedback you want to provide today on the overall structure of proposed work plans, subcommittee composition. We're asking committee members to review the proposed structure and work plans and then provide feedback by July 10th so that we can have all proposed revisions for the committee to review prior to any vote. And then based on your feedback, we'll refine the proposal before the next meeting and return for formal action at a future meeting. Following approval, we can discuss, the process of appointing members and identifying subcommittee chairs and begin scheduling meetings.
This is Kyle Gay. I'm just curious, it says that the chair has to attend all meetings in person. That's not even a requirement that we have on this board.
As a requirement.
Okay.
It's in our
Oh, so you have
legislation.
to?
Is the anchor
Yeah.
location.
Got it.
Yeah,
Okay,
yeah. And the subcommittee member chair being a voting member of the SCBC is also in the law.
that part is fine. Clarification, is it saying you have to be here in person every time?
Says the chair of the SCBC.
Is that because of the FOIL, is that a reference to the FOIL law or reference to SCB code?
It's in SCBC code.
So I think I'm just flagging you, if there's a bill out there, we should take a look at that, because especially if the change is for the healthcare commission chair, that could be not sustainable practice if the individual is not a paid state employee. And I do think that this requirement means that quite a few individuals in this room would be unable to commit to all subcommittee meetings unless, and I don't want to say what the cadence would be, if it's a quarterly meeting and it's scheduled around, like, if Representative Bomback is a chair, I know he has a robust travel schedule and I really am jealous of that. But I would say that if that doesn't change, we really need to make a robust effort to be working with whoever, because we need the best people in this space, not just people who can necessarily be in person.
Mayor Peterson?
Yes, thanks, Mr. Chairman. When the RHBAS was created, it was done by statute. And I've always wondered where the statutory authority came from for the SEBC to appoint subcommittees. And maybe somebody can get back to me and tell me where that is in the code. And my second comment has to do with what Bill Overly talked about, and that is qualifications of designees. And I know we're going to discuss that some more, but we should also be mindful of Senate Bill 289, which would, if it passes and is signed, would require that the retiree designees get the approval of their appointing authority to name a designee. So that would create like two steps for retiree members of the SCBC. One, to go back to the person who appointed them, and then to have to go through a process within the SCBC. So I just want to throw that out there so we can be mindful. I know there are a couple bills floating around, as Lieutenant Governor Gay just mentioned, that could, change some of this. But I am interested in the statutory authority for appointing the subcommittees. Thank you.
Happy to follow up with that.
Overly.
Yeah, just a couple of general thoughts and following up on the Lieutenant Governor's comment about perhaps meeting quarterly, having served on a subcommittee for several years, we met on a monthly basis, and that probably wasn't enough, quite honestly. Given what we were required to deal with. In fact, we probably should have made it several times a month, but that being said, and just for general consideration moving forward, I put forth on a number of occasions when we had the financial and policy subcommittees in place, that there was so much overlap in terms of what we were looking at. Financial influence policy, policy influence financial. So when I see, the proposal to have two separate subcommittees where there's a lot of synergy and overlap, that doesn't really make a lot of sense to me. And I would at least offer up for consideration, considering one subcommittee that would undertake all the charges that are laid out in here. I think it would be more efficient. It would cut down significantly on the load on SBO and certainly on Willis Towers Watson if you consolidate it. So I just throw that out as a general thought for consideration.
I would definitely welcome other committee members' thoughts on that. I think one of what we were thinking was where there's overlap, we could possibly schedule some joint meetings, but if the desire to start with one committee and see how that's going.
Yeah, I saw where that was laid out in your proposal that we could meet jointly. I'm just saying, I think we could save a lot of time, energy, and effort if the subcommittees were combined and all focused on the same issues at the same time, since there is that synergy.
Lieutenant Governor again?
This is Kyle Gay. I understand the government efficiency argument, and it's a good one, but I wonder what's the difference then between the work of the subcommittee and this committee? Is it just that they meet more and talk more, and then, right, I want to make sure that we are giving ourselves an opportunity to specialize in the questions that we're asking. And I was pleased to see, kind of to your point, that there aren't 5 recommended, right? I feel like this might be a good balance, but I will be honest, I think we do need the time before July to take a look at the strategic plan, where you want these committees to operate. And I think you're open to feedback on which buckets fit where.
Absolutely.
Okay, yeah, great.
Any members?
I will send out an email reminding everyone a little bit before July 10th that we're looking for your feedback.
But not on July 4th, you won't send it, right?
No, I won't see that.
We're going to move on to agenda item number 7. It's Senate Joint Resolution 7. There's a report requirement with regards to that Senate Joint Resolution 7, and I think we're giving an update on that.
So I'm going to now provide you a high-level overview of the draft SJR 7 report. And this report fulfills the committee's obligation under Senate Substitute 1 for Senate Joint Resolution 7 to evaluate prescription drug cost containment strategies and report on implementation challenges no later than August 1st. But before I go into the substance, I want to briefly orient you to how the report was structured. The report begins with an executive summary, which highlights the key actions taken, major challenges, and overarching themes, particularly around PBM transparency, procurement constraints, and market dynamics. It then provides background and context, including the timing of the PBM procurement, which is central to understanding many of the report's conclusions. From there, the report walks through each strategy identified in the resolution, in a consistent format, so that the strategy itself, then implementation considerations and challenges, actions taken by the committee, and then where possible results. And then finally, throughout the report, we highlight some cross-cutting themes such as legal constraints, operational complexity, and trade-offs between cost, transparency, and member impact that apply across multiple of the strategies that were listed in the resolution. The structure is intended to make it easy to see both what was required under the resolution and then how the committee responded to each component. One of the key takeaways and a central factor in shaping the report is that the committee did take some meaningful good faith action on every strategy in the resolution, even with the timing constraints due to being in the middle of an active PBM procurement. Rather than delay progress, we embedded those strategies directly into the ongoing PBM procurement process. And in order to maintain the integrity of the procurement process, we can't really disclose vendor responses or outcomes at this stage. As a result, the report does appropriately focuses on actions taken and feasibility rather than final results. So I did want to highlight a few key actions taken. We incorporated transparency, pricing, and oversight expectations directly into the PBM RFP, both in the minimum requirements and vendor questionnaire. We ensure the state retains the ability to pursue options like direct contracting, specialty carve-outs, and alternative supply models. And we engage directly with pharmaceutical manufacturers and third-party vendors to evaluate alternative pricing models, particularly for high-cost GLP-1s. And then we aligned many of the reporting requirements in the PBM RFP that the committee approved at the March 9th meeting with transparency requirements of the upcoming Consolidated Appropriations Act. I did want to point out a few key challenges that are listed in the report. A consistent theme across all the strategies is limited transparency in the current PBM model. We also face legal constraints, including trade secret protections and contractual limitations. Some strategies require significant infrastructure or market changes that cannot be implemented immediately. And then in several cases, there are real trade-offs between transparency, cost, and member experience. The report meets a statutory requirement, provides an accurate account of what was feasible at this stage, and it documents the actions that we took that will influence the next PBM contract. It also creates a roadmap for continued exploration of the strategies as procurement concludes and federal reforms take effect. So the next steps for the report is we will need to vote to approve the report at the July 27th SCBC meeting. And so that we're utilizing the SCBC meeting time most efficiently, we're asking that you send any requested revisions by email to me no later than the end of day, Friday, July 10th. And that'll help us to have the revision in writing prior to the meeting. And we can send out a marked up document with the materials for everyone's review prior to that meeting. And that way we're not trying to capture those requests and edit the document during meeting time. And again, I will send you a reminder out a few days prior to the due date. But I do welcome any comments or feedback that you have on the report today, if anyone would like to.
Thank you for this report and the opportunity to give feedback. Am I right that it's a one-time report, not an ongoing report?
Yes.
And then if there were to be a request for a follow-up based on the things that we can't comment on right now because of the ongoing process, what would the timeline be for that follow-up?
We would have to complete the PBM procurement process and likely.
And the contract negotiation piece as
Yeah,
well?
likely we'd have to get through all that to be able to report out on any results of any of those strategies being put into the RFP.
That's helpful. I just, when our legislative colleagues are asking us about this, I think it's helpful for us to have the right
Yeah.
messaging as well. So that
Exactly.
it's not just, looks like a lack of transparency for that sake. So
Yeah.
thank you.
Hold on that.
And I sent this in email in advance to the chair. There's many places where it says WTW recommended incorporating, but there's a report of the SCBC. So should it not be the SCBC, incorporated or whatever? This is not a report on WTW. So can that wording be updated?
Yeah.
And also to go back to the previous issues, subcommittees, that wording's not required that the chair be in person, it's the chair or the vice chair. So if the chair is a very busy person then the vice chair can be the person at the anchor location and physically present. So want to correct the record. And for that matter, if the subcommittees had a vice chair, then either the chair or the vice chair would need to be at the anchor location, but it wouldn't require solely the chair of the subcommittee at the anchor location.
And this is Kyle Gay, but then just a flag, my understanding is the legislation removes the vice chair position as well. It keeps the vice chair position. Okay, great.
I think it's silent on the vice chair position, so I don't think it changes anything. Right.
Okay.
Changes the chair. And it does things on quorum, and it does a lot of things, including removes the treasurer.
Be sure to send out a reminder.
Right. Agenda item number 8, reference-based pricing, Bailiff Health.
Hi, good morning, everybody. Can you hear me? Just making sure my audio is working.
Yes, we can hear you.
Okay, great. Good morning. My name is Alyssa Vangeli. I'm a managing director at Bailiff Health. If we could go to the next slide, please. So my colleague Sarah and I will be giving today's presentation on reference-based pricing. So a little bit of background on Bailiff Health. We are a health policy consulting firm located in Needham, Massachusetts. We have a broad geographic reach, having worked in 46 states and Washington, D.C. Our clients include federal, state, and local government agencies, healthcare purchasers, health systems, foundations, and national organizations involved in health policy. So again, my name is Alyssa Vangeli. Managing director. My work primarily focuses on partnering with states on projects to advance healthcare affordability in the commercial market. I'm so pleased to be with you all this morning, and my colleague Sarah Kinsler and I will be co-presenting today. On the next slide, please. Before delving into our presentation, we thought it would be helpful to provide just some brief background and context on some of what we know about hospital prices in Delaware. So this slide shows data from the research firm RAND. RAND periodically analyzes U.S. commercial hospital claims data, which includes adjusting for the mix of services each hospital delivers and comparing commercial payments to what Medicare would have paid the same hospital for the same service. So when we compare commercial payments to Medicare for Delaware hospitals, we can see that some hospitals' outpatient prices are more than 3 times what Medicare would have paid, while inpatient prices are more than 2.5 times what Medicare would have paid. And looking across the countries, you can see from these deciles, these are some of the highest relative prices nationally in the very top deciles. You'll also note that the deciles do differ by hospital. RAND's data shows that prices vary widely across hospitals in the state, as does relative price. So at a high level, reference-based pricing is a strategy that limits how much hospitals are paid for a defined set of services, most often including both inpatient and outpatient services. And these payment limits are established in reference to an external benchmark that's typically set as a percentage of Medicare reimbursement rates for the same service. Reference-based pricing can apply to either the contractual rates that commercial insurers pay to hospitals or the amount that a hospital bills or charges. As you can see here, other terms used to describe the strategy include price caps, price limits, payment caps or limits, and while some of the terms can be used interchangeably, some may be more appropriate based on the design and mechanics of the strategy, which Sarah will talk about shortly. And I'll just note that because reference-based pricing directly addresses a primary driver of healthcare spending and spending growth, it can be one of the most effective tools for controlling prices that are excessively high at hospitals. The strategy's impact, however, primarily depends on the cap level and how broadly the cap is applied, as well as some other important policy designs decisions, which Sarah will speak about now. So I'll turn it over to Sarah.
Thanks so much, Alyssa. You can all hear me?
Yes.
Excellent. I'm Sarah Kinsler. I'm a senior consultant here at Baylor Health, based in Montpelier, Vermont. So it's so nice to be here today and to see you all. So I'm going to talk about some of the ways that states can tailor reference-based pricing policies to really make sure that they match up with state goals and state authorities. And I won't read this list through to you here because we're going to talk about each of them individually. So as you've already gone to the next slide, thank you. So states can choose to apply reference-based pricing very broadly to the full commercial market. Here in Vermont, they're looking at applying to the full commercial market through provider rate setting and direct regulation of hospital providers. States can choose to apply to the state-regulated commercial market of fully insured individual, small group, and large group plans, or slightly more narrowly to specific market segments, such as public employee health plans or a public option plan. This can also include specific reference-based pricing provisions related to out-of-network payments where authorities allow, and typically that requires legislation. So if we move to the next slide, we'll talk a little bit about application to hospitals. Application to hospitals is another opportunity to customize. States can apply their caps across the board to all hospitals. They can incorporate exclusions or accommodations based on hospital type or phase in for some hospital types or types of care like professional services. Professional services. One common exclusion has been critical access hospitals, of which Delaware has none. Even so, as Alyssa's slide earlier showed, there are major differences in payments between hospitals. Bay Health is in the highest decile nationally for inpatient prices, while Tidal Health is in the lowest. And so there are definitely opportunities to kind of target application of the caps. As we go to the next slide, in terms of services subject to the caps, states have typically applied caps to inpatient and outpatient facility services, but states' approaches really can vary based on policy goals. Reference-based pricing can be applied narrowly to high-price services. So if they're, a particular service like emergency department services are super high-priced, you could select a service to target that way. Additionally, reference-based pricing could be targeted, applied narrowly to out-of-network services, as I mentioned earlier, or it could be a more comprehensive approach to also include professional services. On the next slide, we'll talk about a key policy decision and opportunity to tailor, which is selecting the referenced benchmark and cap levels themselves. In most cases, reference-based pricing policies have used a percentage of Medicare as a reference point, a starting point. Many commercial insurers and hospitals already set their contractual rates as a percentage of Medicare hospital rates, which adds some convenience. And the methodology is also public and transparent. It's updated annually, and it includes adjustments for certain input costs like geographic variation in wages. But on the next slide, we'll talk a little bit about the different flavors of that policy option. So in addition to where the cap level is set, the allowable percentage of Medicare, which Medicare rate we're referencing can have a really significant impact on the actual dollar amounts that are allowable under reference-based pricing. So to date, states have used Medicare's full payment rates, including wage index and hospital-specific adjustments for things like
Can you pause 1 second?
Yes, of course.
Sarah, this is Paul Baumbeck. In the earlier slides, there's the issue of payment caps and price caps, and they're quite different, but it feels like you're using the term caps without indicating which you're speaking of. Can you try to be clearer when you're talking about caps?
Yeah, absolutely. And I will say I have been using them quite interchangeably in this conversation, and I would invite Alyssa to jump in as well. I think in this case, we are talking about caps on the amounts that are paid. And so in some cases, like when reference-based pricing is implemented through provider regulation, that could also be a cap on the price that is charged or the payment amount that is accepted by providers. But when we're taking an insurance regulation approach or a contracting or purchasing authority approach, it would be a cap on the payment. Alyssa, do you agree with that?
Yes.
And does that help clarify, I hope?
Yeah, I'm just saying ongoing, you've been using caps a bunch, so if you can just make it a little clearer, that would help.
Yeah, absolutely. Thank you. So So moving back to thinking about Medicare as a benchmark and kind of which underlying Medicare rate we're referring to. To date, states have used Medicare's full payment rates, including wage index and hospital-specific adjustments for things like disproportionate share hospital payments and medical education payments. The alternative is to use what I'll call Medicare base rates, which might include only Medicare's geographic wage index adjustment, which accommodates differences in how much providers are paid across geography. This choice has pretty significant implications for the reference-based pricing denominator. So final Medicare prices reflect all of those payment methodologies and adjustments and supplemental payments for teaching status, for the proportion of publicly insured patients, for rural location, for small size. These hospital-specific adjustments were almost 20% of total Medicare inpatient prospective payment system payments in fiscal year 23. So you can see that that would have a pretty significant impact for some hospitals, at least for hospitals that receive a lot of supplemental payments. So this can be seen as a benefit in that it means that Medicare prices under a reference-based pricing methodology, allowable commercial prices as well, would reflect the costs of these activities and facility characteristics. But it also means that some hospitals receive much higher Medicare payments than others for the same services. So a higher Medicare denominator would mean that Hospital A commercial payments might look lower as a percent of Medicare than Hospital B, even if, as you know, in dollars, they are higher. Using Medicare base or base plus wage index provides a more apples to apples comparison of commercial prices so that we can actually look at that percentage and understand the relative dollar amounts. So if Hospital A's commercial reimbursements are actually higher in dollars than Hospital B, that will show in the percent of Medicare because the denominator is relatively consistent. That said, it doesn't reflect things like graduate medical education and disproportionate share hospital status. So some might see that as a disadvantage. So really there are multiple ways to do this, and that states have thought about approaching setting these levels, and there are benefits and drawbacks either way. Moving on to my last slide, and then I'll hand it back to Alyssa. Finally, implementation and enforcement is another place where states really do have options. And the choice here is going to tie really closely to that first slide that I presented on which market segment or segments might be included in a cap. So for states focused on public employee health plans, state purchasing authority can be an important lever, which doesn't necessarily require new legislative action or authority, although legislation can make a reference-based pricing program less subject to changes in carrier procurement cycles and can enable complementary changes like limits on out-of-network payments. Insurance regulation is appropriate when the target is the fully insured commercial market, and that can be done either through rate review or form review and market conduct, depending on existing state authorities or new state authorities. And then finally, the broadest approach is provider price regulation, which, as I mentioned earlier, would impact the full commercial market regardless of plan type or sponsor by limiting what hospitals can actually charge for their services and receive. So I'll note that any of these implementation and enforcement options can also include consumer protections to prevent things like balance billing, whether that's through statute or through contractual provisions. So we can ensure that these policies don't have an outsized impact on consumers who would be required to pay a balance or something like that. So all of that said, I'll pass back to Alyssa to talk through some of the existing models that are currently implemented or being implemented in states. Thank you.
Great, thanks so much, Sarah. So we're going to end the formal part of this presentation, giving an overview of existing state models, and then we'll open it up to some discussion. So starting with some of the models that have been in place pre-2025, Oregon has the most extensive experience to date implementing a hospital reference-based pricing policy. Since 2019, Oregon has instituted payment caps for the state's public employee plans, beginning in late 2019 for public educators and then in early 2020 for other public employees. Under the policy, the state's contracted insurers and third-party administrators must limit payments for inpatient and outpatient services to no more than 200% of the Medicare rate for in-network hospitals and to no more than 185% of the Medicare rates for out-of-network hospitals as an incentive for hospitals to remain in-network. Oregon's policy remains in effect today, and I would say provides some of the strongest evidence of success based on evaluations conducted thus far. There have been a few evaluations that are a little bit old now, but the first being that an evaluation of the first 27 months of implementation found that the policy yielded 107.5 million in savings for the state, amounting to approximately 4% of planned spending. And then a separate evaluation found that individuals in high cost sharing plans experienced a 9.5% reduction in out-of-pocket cost spending per outpatient procedure as a result of the policy. Washington State has a different type of policy in place for their limited to their public option program. So beginning in 2021, all public option plans have been required to cap aggregate statewide hospital reimbursement at 160% of Medicare rates. And just noting that this cap applies at the aggregate level, not service specific, as we see for Oregon and for other similar types of policies. Montana implemented a reference-based pricing policy from 2016 to 2022. Applied specifically to their state employee health plan, and rather than establish straight payment caps, the state negotiated and contracted with each hospital to reimburse at ranges of Medicare payment. So those ranges were 220 to 225 of Medicare rates for inpatient services and 230 to 250% for outpatient services. The program did end in 2023 when the state selected a different third-party administrator for the state employee health plan. There's been one evaluation of that program to date showing that the policy generated an estimated 47.8 million in state savings over the course of 3 years. On the next slide, we have some newer policies, some in effect and some still in the pre-implementation phase. New Mexico passed legislation in 2025 authorizing hospital payment caps in the state employee health plan, reference-based pricing. The legislation's broad directive included this policy to help offset enhanced financial support for state employee coverage. The New Mexico Healthcare Authority, which administers the state employee health plan, issued program guidance dictating the levels of reference-based pricing. So starting in July 2025, the Healthcare Authority no longer reimburses in-network hospitals more than 200% of Medicare and out-of-network hospitals no more than 175% of Medicare. And I'll just note that this policy applies only to urban hospitals located in counties with populations of 125,000 or more. The law was recently expanded to require that the school-based health plans also implement reference-based pricing, and that will go into effect in July of this year. Bumping over to the right on this chart, Washington recently, well, in 2025, passed a similar policy limiting hospital payments in the public employee and school-based health plans. The legislation limits hospital payments to 200% of Medicare for inpatient, outpatient services, and then for out-of-network services limited to 185% of Medicare. This policy will go into effect January 2027. And Washington's legislation had a complementary policy aimed at sort of rebalancing healthcare spending in the state, establishing minimum payment levels for both primary care and behavioral health services, establishing payment floors of 150% of Medicare rates. Sarah noted Vermont's policy, which is more broadly applied than looking at state employee health plans. So Vermont's legislation directs the Green Mountain Care Board to implement reference-based pricing for Vermont hospitals, which will be phased in over several years, beginning in October 2026. The legislation uses the Green Mountain Care Board's existing provider rate-setting authority to implement the requirement across both fully and self-insured commercial plans. Again, establishing reference-based pricing at the provider level, capturing the entire commercial market, and directing the agency to establish price caps for hospital services at a percentage of Medicare rates. The actual percentage of Medicare rates is still in development. The law also establishes the Green Mountain Care Board to ensure that savings are passed along to ratepayers through lower insurance premiums and to report on this requirement annually. And then finally, in 2025, Indiana enacted legislation which established 2 hospital payment price cap policies. The first requiring the state to set a cap in 2026 based on statewide average payment rates for inpatient and outpatient services. The 5 largest nonprofit hospital systems must reduce their aggregate average inpatient and outpatient prices to below the statewide average by June 2029. And if a nonprofit hospital fails to meet that requirement, the hospital must forfeit its nonprofit status until it lowers prices below the average. The second policy requires the state's largest hospitals to offer direct-to-employer contracting arrangements with a cap set at or below 260% of Medicare reimbursement rates for inpatient and outpatient services. So that's an overview of the policies that have been in place and that will soon be in place. And we're happy now to take any questions.
Hold on that.
Yes, can you, for the Oregon, and let me start with, help me understand. So I go in for procedure, it's billed at 20 at a facility, it's billed at 20,000. If it's the insurance company have insurance policy, they look at it and say reasonable is 10,000. That's contracted if they're in contract. And that 10,000 is a percent of Medicare. My insurance policy pays 80%. I pay 20%. I'm on the hook for 2,000. If I've gone out of network and you've got a lower percent rather than that, rather than whatever 200% is 175 or something. So their reimbursement may only be 7,000 instead of 8,000. If I'm out of network, am I responsible for the $12,000 difference? I'm trying to figure out if the out of network being less than Medicare, does that mean more dollars owed by the patient, or is that where the balanced billing comes in? And does Oregon have that balanced billing?
Sure. So the I'll try to answer, but please let me know if I'm not sufficiently answering your question. So the cap level applies to the contracted rate that the insurer in Oregon's case, the state employee health plan, pays to the hospital. So it doesn't actually dictate specifically the amount that a member will pay. It's not directly impacting plan design. If a member's out-of-pocket cost is based on something like coinsurance, which is a percentage of that contracted rate, then the member's coinsurance would be impacted because the coinsurance amount is based on that contractual rate. But in this case, and there are some, and this is where the terminology gets a little confusing, there are some policies that do apply sort of payment caps to plan design specifically, but this particular policy is not doing that. It's applying the cap to the contracted rate. So the balanced billing protections come into place because we still would not want a hospital to try to sort of recoup that difference, that potential amount lost, by then charging a member that difference. And so that's why it's important to sort of couple some of these policies with balanced billing protections. Does that answer your question?
Out of network, it's sort of by definition, they're not under contract. So
right.
How does the state prevent that lower reimbursement rate for that procedure to not affect a higher bill for the person for that difference in percent of reference?
Sure. So all of the state laws that have included complementary out-of-network payment caps do so via legislative authority. So that's authority that is not that is needed to require contract arrangements with out-of-network providers. A state would not be able to do that if it didn't already have statutory authority on the books requiring lower out-of-network rates.
My last question is on that slide on Oregon, it's 107 million over 27 months.
Mm-hmm.
They've got times our population. That's for more than 2 years. that seems like not a drop in the bucket, but certainly not a big savings for a state like Delaware if you scale it down. Am I missing?
A couple, well, I guess I would say I'm not, I don't know offhand sort of how the numbers of the, you know, insured members in Delaware compared to Oregon, but I'll just note a couple of things about Oregon. Oregon does have significant exemptions for its policy. So it exempts critical access hospitals, certain rural hospitals. And I think the amount of sort of hospital spending that's excluded from the policy is something like 40%. So some of the exclusions and other policy design decisions certainly would impact the amount of savings that Oregon experienced. I'll also note that particular evaluation looked at the first couple of years that the program was implemented, and in the first year, there were some actions to raise certain prices up to the payment cap more significantly than the state, I think, would have intended the policy to be applied. And so the state subsequently issued regulatory guidance stating that the price cap should be the lesser of the payment cap amount, the contractual rate or bill charges, and that lessened the sort of the increase in rates up to the cap level. So if you're looking at just savings in the second year, the savings are more, but if you're looking at savings across the first 2 years, you're seeing some of that impact of raising rates closer up to the cap than what the policy was intended to do.
Thank you very much.
Bill Overly and then Karen Peterson.
Yeah, Bill Overly. Maybe this is best posed to Sarah, since she's located in Vermont. In Vermont, you said they're moving to 200% of Medicare for in-network and 185% for out-of-network in October. And in a post reference-based pricing environment, I'm trying to understand how that influences the mechanics of the TPA and the process. For instance, in Delaware, I mean, the TPA goes out and negotiates pricing, and we simply pay what they've negotiated. I'm trying to understand how that dynamic may change in Vermont as it relates to TPA usage.
So Vermont actually has not set its reference-based pricing levels yet. And since they're taking a provider regulation approach, the state is really regulating what providers can charge and accept rather than kind of what's in the contractual relationship. So my understanding of how Vermont will implement this is that, you know, there will be requirements on providers, what they're allowed to charge, what they're able to accept, and that should flow through to their contracts with payers, including the state's TPA. In states, so I think you may be referring to New Mexico, which has implemented at 200 in-network and 175 out-of-network, and they're focused on the public employees as a population. My understanding is that basically this is the state saying, okay, new statutory requirement, and that this is a requirement that applies to how our TPA will contract with hospitals that this policy applies to. And so it's creating a new contractual requirement for TPAs to say, you know, this is how you're required to relate to hospitals that are subject to this policy, and how you'll be required to pay them as well. Alyssa, do you have anything to add to that?
No, just to say that I think in Oregon and Washington also have a combination of fully and self-insured plans for their state employee health plans, and so the policy does apply both to the fully insured plans directly, and then also to, again, as Sarah noted, to the TPAs for those self-insured portions of the plans.
Yeah, I'm trying to. When I went through this several days ago, I'm trying to understand again. Using Vermont as an example, once they set the rates, they will not be directly contracting with providers. There still will be a TPA involved in the process.
Yes, in Vermont specifically, so there will still be fully insured carriers. There will still be self-insured carriers, including the state's TPA for the state employee health plan. And those contracts should reflect the, statutorily mandated rates, or the cap level will eventually be set through regulation, but those contracts will reflect those rates.
Karen Peterson.
Yes, thanks, Mr. Chairman. Can you tell me, do the other states typically prohibit balanced billing in their statutes? Or is that just, that's just negotiated?
As far as I know, there have been specific statutory protections that have been pursued for the states that have done this, again, via legislative authority. I think in New Mexico's case, their statute was sort of a broad directive, and so the New Mexico Healthcare Authority subsequently issued program guidance, and that guidance specified prohibitions for balanced billing. So that was not done via sort of legislative changes. But for the most part, states that have implemented reference-based pricing through, with some level of specificity in statute, have included those prohibitions on balanced billing.
Okay, and my second question is, do you have any idea, percentage-wise, how many hospital systems in those states refuse to accept the reference-based pricing rates? I know in Montana, there were one or two that held out, but finally signed on at the end. But is that a problem in the other states where some hospital systems just say, no, we're not going to accept those rates?
So Oregon and New Mexico are the two states that currently have policies in implementation, and to date that they have not experienced any such hospitals stating that they will not accept rates. I think there are a couple of states who will be implementing soon. So we'll be able to share experience from those states as we get closer to implementation. But to date, for those two states, we have not heard of any hospitals specifically saying that they're not going to accept rates.
Okay, so it doesn't seem to be a big problem, at least at this point.
To date.
My last question is, do these reference-based prices, they would apply to Medicare retirees, pre-Medicare retirees, and active state employee plans? Is that correct?
I think that that's really up to the state in whatever way it chooses to apply reference-based pricing. But when we're thinking about public employee health plan, I think that those are choices that a state could make as we think of kind of subsets of that population.
Okay, have any states extended this to Medicaid payments? Which is a huge chunk of our budget.
Yeah, not that I know of. I will say the relationship between state Medicare and Medicaid payments varies. And just like for Medicare, Medicaid supplemental payments can be kind of a big portion of the total. And so how we think about those and include them, impacts how they compare to Medicare. But in many states, Medicaid payments are similar to or lower than Medicare. So they tend to be much, we're not talking about 2 and 3 times what Medicare pays, or even more in some cases when we think about Medicaid rates.
And not that the SCBC governs anything about Medicaid payments, it's just that it's a huge chunk of the state budget. And I was just curious as to if there's any reason that they couldn't be extended to Medicaid. If you could think of any reason that they could not.
Alyssa, you may be able to comment on this better than I think, there's so many federal regulations and provisions related to Medicaid rates and how they're applied that I wouldn't want to misspeak here.
Yeah, I mean, I think most states that have pursued reference-based pricing policies have done so in an effort to contain spending in the commercial market specifically. So there just hasn't been as much focus on Medicaid. So I think that's what,
Okay, thank you.
That's what I'm seeing, yeah.
Secretary, thank you all.
Yeah, I was just going to elaborate a little bit on the Medicaid piece of this. I mean, Sarah's absolutely right. Medicaid prices are generally at or below the Medicare rate. And so a cap at even 150% of Medicare would not actually impact our Medicare prices. We are already paying in most of our markets. Delaware is actually, compared to other states, has fairly generous reimbursement compared to Medicare, but we are still hovering at or around Medicare. And so there's really there's not a lot of space for a Medicare benchmark to make a huge difference unless it was set at, like 95% of Medicare or something like that.
First Commissioner. Thank you, sir. On slide 3, I noticed the hospitals, at least the first couple, their reimbursement. I want to say, is this accurate that their reimbursement is in some cases over 400% of Medicare?
Sarah, do you remember offhand what those levels were? I know.
I've got that data right at my fingertips. So for outpatient services, RAND shows some of those 3 particularly high price systems are over 3, and in some cases over 3.5 times what Medicare pays for the same services for outpatient services. And then when we're looking at inpatient services, we've got a couple of hospitals above 250% of Medicare and one above 300% of Medicare. So 3 times what Medicare pays for the same services. So, and I found it helpful to dig into this data a little bit to understand how that relates to other hospitals in the country. So is 300% really, really kind of an outlier nationally, and it is more so for inpatient than it is for outpatient a little bit, but yes, it is. And so the nice thing about the RAND data set is that it allows us to look at Delaware in context and give some context to these numbers.
So for the bottom 2, St. Francis and Tidal Health, would you say that their reimbursement currently is less than 250% Medicare?
One moment, please. For outpatient, it is, and for inpatient, it also is. Yes, that's correct. I will note that this data is from kind of 2020 to 2022. So they're redoing the RAND study right now, and it'll come out again next year. But there's a lag in this data, so it's not the most current data. But we don't have reason to think that it's wildly off base either. So this just kind of gives us a sense.
Yeah, the reason I asked about 250, I'm sure you're aware of SB1, and that's sort of the target, 250% of Medicare. So the question is for St. Francis and Tidal Health, if they were reimbursed at 250% of Medicare, would they essentially see a raise?
I'm sorry, I don't think I heard the very end of that question. It seemed like sound cut out.
Would they see a raise? Yeah.
Thank you. Sorry, I thought I heard would they see a rate. So I think that depends. And actually, I was hoping I would be able to address. I think I misspoke a tiny bit earlier when we were talking about the relationship between the contractual prices and TPAs and regulatory prices. So I think when Alyssa was talking about kind of lessons from Oregon and ensuring that prices aren't immediately up to the cap level, that can significantly eat into savings. So we don't necessarily want to say every hospital that's below the cap should move up to the cap right away. One complementary policy that Delaware could consider is a price growth cap, and this is something Delaware already has a version of this, but in the context of reference-based pricing, it would limit the amount that prices for any particular facility or how procedure would kind of be allowed to increase each year. And so in these cases, carriers or the TPA would still be in a position to negotiate with St. Francis and with Tidal Health to think about, okay, how much of a raise each year. Eventually, one assumes that they would hit the cap level and be prevented from kind of growing further. Alyssa, do you agree? Have anything to add?
Yeah, that's right. And I think that's what I was referencing to in thinking about the sort of unintended impacts in Oregon's early years of implementation. So they did see some rate increases for services priced below that cap level. And so their regulation sought to sort of clarify that this wasn't meant to be a ceiling that everybody should strive to go up to, but that the maximum reimbursement amount should be the less of the applied payment cap amount or the contractual rate, the prior contractual rate, or the charge, so that it's minimizing sort of the incentive to raise rates up. But as Sarah noted, having a complementary price cap policy in place would be an even stronger protection against having certain services go up to that capped amount.
Just a question. I'm sorry.
I've got a couple more, but if that's.
I was just curious on where the greatest volume of care is being administered to state employees. Is it Bay Health? Is it BB? Is it Christiana? I could make a guess, but
I don't think they could answer that. Well,
It's
if I could be more present.
Sure.
so Christiana, if we were to put a price cap on Christiana, we may see individuals crossing to University of Pennsylvania sort of centers, Philadelphia centric centers for care, also diverting their care to St. Francis potentially, to a lower cost center, and similar with Bay Health and BB. I mean, they wouldn't be able to consume all of that volume, but is that a safe assumption?
Is that a question for Alyssa and myself?
I mean, I think the other question is, maybe I'll just sort of leave that more as a rhetorical question. From RAND's data, again, I think you clearly stated that it's 2022, so it's relatively old data. When will you have, or when will the RAND data be out next year?
That's a great question. I believe that they've said publicly next summer. Alyssa, does that fit with your recollection?
That rings a bell, but I would say that we want to confirm.
Yeah.
Before.
Yes, and we should say we are not, we don't work directly with RAND on this study. We kind of collaborate with them to understand their data and to kind of learn from each other. But we're not involved in the production of this study, so we can't make any promises on their behalf. But I believe in kind of middle towards second half of next year is my memory. I'll be excited to see that data and to see kind of what we can understand from that as it gets updated. In terms of patient migration as a result of reference-based pricing, my thinking is that having lower prices at local hospitals wouldn't be something that would spur out migration and kind of moving towards the Philadelphia systems. I'm not sure why a consumer would necessarily leave Christiana if they're already, going to Christiana and paying the existing prices. If prices are reduced, I don't think that would necessarily cause someone to leave.
It's a good point. I think that we have hired and paid consultants a significant amount of money to care to centers outside of Delaware in the past, and so that may be lower centers of care, lower cost centers, not lower quality.
Mm-hmm.
And so that's kind of where that assumption's coming from as far as migration of care.
Can I just comment on migration of care, do you mind? I know.
No.
This is Kyle Gay, and because I think this is an important point, because we hear arguments on both sides of, actually multiple sides, because I think there's crazy amount of sides in this debate. And the theory that is posed is it's not necessarily that the consumer will acknowledge the price difference, it's that there will not be options in Delaware where we can regulate, and that people will be going and paying in non-regulated or non-capped centers outside of the small state that we can regulate. So I think that might be part of the migration question too. And I think it's like this balance of like, what I hear or what I'm like learning, and I think from this presentation, is that there's gonna be a combination that we can seek out of policies that help us to think about costs, but also not just drive people to Penn and Hopkins where we can't regulate how much it costs and we're gonna end up paying out of pocket. Well,
So yeah, I think you make a good point. It is something that we have done, right? So when we hired what used to be what was it called?
Surgery plus.
Thank you, Surgery Plus, now Lighthouse, you know.
Lantern.
Thank you. When we hired them, it really was incentivizing the employee to receive a cash benefit in order to divert their care outside of the state.
Mhm.
And at the end of all of that work, it was to try to help lower the cost and not necessarily lower the quality. And so again, I think that when we talk about migrating care and diverting care to other resource centers, we may be slowly, diminishing the quality that's here because reimbursements start to change. So I'm just saying that it may be something to consider. I think the other thing to consider is the fact that this is very old.
He's allowed me to jump in.
You wanna jump in? Jeff Tasher.
One factor that's not been discussed here is the fact that Delaware's a closed market. So the reason we have to go out of state to Hopkins and Penn is because we have a scheme that doesn't allow them to come into state. And that is, we keep hearing over and over again, we are such a closed, non-competitive market. So, why do we give into them and the fears they generate? Why don't we redirect this and say, let's get the competition we need in Delaware to help drive the prices down? So it's a factor that's not being talked about here in this part of it, but that is a huge problem that we have heard over and over again. Right? We have to go to Penn because we don't let Penn set up shop in Delaware. We have to go to Baltimore because we don't let Hopkins. They want to do it, but we have a legislative prohibition against it. So let's open up the market.
this is Kyle Gay, and the HRB reform is part of that initiative, right? That's connected to the rural healthcare grant, and that's the bill that's making its way through.
Sorry, yeah, Tashner, sorry.
Sorry, okay.
It's-
But so I think there is movement in that
Yeah.
direction, which we should watch as
Yeah,
well.
and I think we should say that, that's part of the problem we've been dealing with for years. And I know Willis Towers Watson has pointed it out over and over again. You have one of the most closed markets in the country. And that's why, quite frankly, they're able to get away with this. You pointed it out, Insurance Commissioner, to me, that chart is really embarrassing. It's the tale of two provider populations. One that is large and is giving us prices that are way above what they should be. And then the small hospitals that are struggling to get by. And, as policymakers, we should be embarrassed by that chart.
Well, not only large, but getting larger by the day.
No disagreement here.
Parks Commissioner, back to you.
Thank you, guys. I forgot what I was gonna say now. No, I'm just kidding. On slide 3, I noted that Nemours isn't listed there. And I was wondering if that was intentional or why that wasn't on the chart.
Sarah, did you hear that about?
Yep,
about
sure.
Yeah.
Sorry, I thought you were about to respond. I
Oh,
can
no,
respond
go
to that.
ahead.
Yeah. So children's hospitals are paid differently than general acute care hospitals. And the RAND data set is really limited to hospitals that are paid under the inpatient prospectives payment system. So unfortunately, Nemours is not included in the RAND data set. So we aren't able to compare them to national.
Just 2 more. On slide 12, where we've mentioned Oregon and their efforts at reimbursing 20% of Medicare, did any hospitals in Oregon go out of business because of this?
So, so there's been the evaluations conducted in Oregon and the conversations we've had with state officials. And so our understanding is that there haven't been sort of any impacts on hospitals that can be directly correlated to the policy that are resulting in hospitals closing or other sort of unintended impacts on access or quality. They also in the first study did look at the impact on prices outside of the regulated market. So price impacts outside of the state employee health plan, and did not see any sort of cost shifting to increasing prices outside of the state employee health plan. So to date, we have not seen any such impacts in Oregon.
That's at
And the
200% Medicare.
That's at the 200% of Medicare for the state employee health plan. Yeah.
So
With again, some hospital exemptions, just to note that we discussed earlier.
if a hospital sees a lot of a larger population of Medicare patients already, and I'm talking about specific to SB1 where we're looking to limit reimbursement at 250% of Medicare. So if a hospital already sees a large number of Medicare patients due to the location or due to the population in that area, are they unfairly impacted on reimbursement versus hospitals who see a variety of payers?
I don't think so. The policy would apply not to Medicare prices, but to prices for commercial plans. So, it'd be impacting potentially their commercial revenue. I will say, and this links to a prior comment, the relationship between price and quality is not super linear. Higher prices, the literature does not suggest that higher prices equal, better or higher quality care. And so by constraining prices or constraining growth in prices, where I think that needs to be done thoughtfully and the levels need to be set carefully, but there's not necessarily, a direct impact that we would expect to see on, quality reduction as a result of that. Of course, monitoring for unintended consequences to make sure that quality and safety are paramount. That's got to be critical, but we wouldn't necessarily, based on the literature and the evidence that we have about, Oregon, for example, we wouldn't necessarily expect to see disastrous financial consequences or disastrous quality consequences. Alyssa, do you agree with that?
Yeah. Sarah.
Thank you, Mr. Chair.
So, Paul Bombach.
Thank you. So, one of your slides talks about phase in certain hospital types or services, and we've got a discussion coming up on diagnosis related groups. My question is there enough data to draw any conclusions on phasing in certain hospital types or services as it relates to, shall we call it, the whack-a-mole phenomena, where if the hospital is not making as much profits in some of these higher cost ones because of this phase and reference phase, is there a tendency to shift some of their prices and bring prices up in other underregulated types of services?
I do think that there's some risk of that when we think about service types. So, if we're looking at inpatient only, there's potential that outpatient prices, could rise or vice versa. So that's something that is definitely worth considering. I think where we haven't really seen that kind of whack-a-mole or cost shifting is between markets or between payers. But I would worry about cost shifting across types of services potentially. I think what we were really referring to there is, for example, bringing in professional services later, which tend to be much lower priced and much closer to, 100 or 150 or maybe 200% of Medicare, but they tend to be closer to the 150% range. And another comment that I don't want to forget to make is, so this RAND data is not the most current, but there's potential, states and state employee health plans have done repricing studies directly using all payer claims databases or using claims directly from the payer. So, there's absolutely opportunity to do studies to, get a more current state that's specific to your plans and your offerings.
Thank you.
Any other questions?
Just one statement. To Colleen's comment, I'm sorry, it's Trinidad Navarro. Colleen's comment about this being old data. We're waiting for the new data. The only I can say is from 2022 till now. The one thing we know for sure is the prices will continue to go up. So it's not going to get better.
Right.
Well, thank you for your presentation. We're gonna move on to agenda item number 9.
Thank you all for having us.
Thanks so much.
Good morning, I'm Walt Matei, I'm with Truven Meredith. We're the analytics consultant with SBL. Today I'm going to cover at a high level recent comparison we did between the allowed amount per admission compared to reimbursement benchmarks that we have in the Vermont scan data. The objective is to identify a couple areas where costs exceed market norms and white fair numbers. And some priority areas for consideration. So the market scan reimbursement benchmarks draw from over 350 large employers. The ones we're using right now are based on calendar year 2024. Go to the next slide. And we're focusing on the commercial population, so the Medicare population is excluded from this. And we're looking at claims from the GHIP for FY25 compared to the calendar year 24 benchmarks. We actually have 4 different metropolitan statistical areas we can look at. We got the Philadelphia, Wilmington area, the Dover area, the Sussex area, and the Baltimore area. This is one focused exclusively on comparisons with the Philadelphia, Wilmington area, which is where most of the action is anyway. So, but we have the ability to go down and look at the other hospitals in small areas. And it includes all the Delaware hospitals, including the Moores, and it's in-network payments on. And also, we're looking at facility and professional separate. So, if you go back to the previous slide, yeah. So there was about 136 million in FY25 spread across 414 DRGs. Most of it was in the facility bucket, and there's about 12 million in the professional bucket, 123 million in facilities. This is about 3,900 admissions we're looking at. If you look at the median benchmarks and compare it to the allowed amount that was paid in FY25, there was an excess of $51.8 million in the facility costs, in excess of $2.6 million in professional costs. So there's a lot more opportunity on the inpatient professional side, but the total excess was about 54.4 million. Go to the next slide. So among the top DRGs that were exceeding benchmark, there were a high frequency of basically deliveries, vaginal and C-section. There's also newborns with immaturity where significant problems where there's over 400 admits that are some of the top DRGs that are contributing to the excess. There's a wide variability in the behavioral health realm, but basically routine OB and newborn DRGs are kind of where you want to start. Some of the the high priority stuff. There's high acuity outliers with ECMO, tracheotomy, transplants, extreme prematurity, which exceeds six digits per admission. Go to the next slide. So, based on all DRG takeaways, are maternal neonatal DRG dominate the volume, NICUs and high acuity DRGs dominate the excess. Facility payments, obviously, are where most of the action's at. And also sepsis, major bowel, and PCI, which is basically stents and angioplasty, are some of the other areas that we want to think about with pathways, treatment, and sites of service, and stuff like that. Go to the next slide. This is looking at all DRGs that are in the 4th quartile above the median. So the highest ones is the top 10. You'll see the top 7 are facility ones with the allowed amount and the total admissions and the total spend in FY25. Go to the next slide. Again, facility dominates OB, NICU, opportunity for centers of excellence to go for high cost cases in ECMO, NICU, and sepsis. Go to the next slide. This is incorrect. So this is actually repeating what was on other slide, but some of the top things in here are really surgical and medical admissions and stuff like spinal, degenerative nervous systems with major complications, seizures, major chest procedures with major complications. And on the professional side, it's things like tracheotomy, bone marrow transplants, and craniotomies. So go to the next slide. Here you see this is surgical case mix review, and there's opportunity to do earlier intervention. This is the distribution of the DRGs by quartile for the facility and for professional. The light blue is quartile 4, so you'll see, particularly on the facility side, over 75% of the DRGs are in that 4th quartile. Got a little bit lesser amount in the 3rd quartile, but the 3rd and 4th quartiles really dominate in where you're at compared to benchmarks.
Is this admissions, not dollars?
This is DRGs. Yeah. It's
Number
basically admissions.
Number of admissions. Okay.
Well, basically, it correlates with number of admissions. So looking at the top 20, and this is kind of throwing out the outliers. So we're looking at where there's only 20 or more admissions for the top 20 DRGs. But some of the outliers are thrown out, so you'll see some things change here. But the top 20 DRGs accounted for 43.9 million, 2,145 admissions. That's about 32% of the total allowed amount for facilities. If Delaware paid for the median DRG benchmarks, you could have saved about 17 million for those top 20, or about 38%. Top 20 for professional claims, again, the numbers are a lot smaller, total about 5.4 million, or about 35% of the total professional spend. If Delaware paid at the median for the DRG benchmarks for professional, you could save about $82,000, or about 1.5%. To the next slide. And this is just kind of recapping what's in those top 20. Again, it's maternal newborn care, high acuity medical surgical DRGs. Again, it's stents, sepsis, major valve procedures. And there's your largest excess per admits, extreme. It says immaturity, but it's prematurity. I would think it's prematurity. Sepsis, major valve, and PCI. Go to the next slide. So again, it's just facility break opportunities for that. And the next slide. I think that's it. And then these are, they're not all labeled, but you'll see that on facility stuff, the benchmark will exceed your, or the allowed amount will exceed the benchmark. If you go to professional, you see the distribution is a lot closer. Next slide. And then I think the next slide is the final slide. Oh, here's a detailed list of the top 25 DRGs by facility. And the next one, professional. And that should be it. I wanted to mention that right now we just looked at DRGs from a high level. We have an opportunity to drill down a lot more. We also have benchmarks for CPT code for procedures that we haven't really looked at yet. There's thousands and thousands and thousands of them there. So we wanted to start off with something relatively simple with DRGs. Any questions?
Paul on that.
So, my question is the what next question. I love numbers. I thank you. And I look, if you just took 4 of the top 5 of those things, you could save about half the dollars by phasing it down to some reference base. But, is that contract renegotiation at our point? Is it for the TPA? Is this a legislative effort? I'm trying to figure out who the actor and what the next step would be if we wanted to use this data and begin some cost saving measures. I don't know who to address that to. So if we were to put, a glide path to reference based on for the most expensive DRGs, if we, Delaware, who's the actor? Is that Department of Insurance? Is that the TPA? Is that directing the TPA? Is that the legislature putting a glide path on price caps? Because if we don't know who the next person is, we know it ain't going to happen.
This is Kyle Gay, just to offer, I think perhaps our council can share with us what some of the powers of the non-legislative options are. And the reason why I would suggest that is because I think we want to be testing and have some flexibility. And I think that we should investigate ways that the administratively or more regulatory, rather than, because it can take a while to get legislation and then to change legislation if it's not working. I just had a quick question. The treatment for the extreme immaturity, is that for the prenatal child?
Well, I'd have to look that up.
Okay.
Yeah, there's different DRGs for, there's several different DRGs.
I just want to point out that even on glide paths to caps, that there isn't Medicare reference-based pricing for a lot of the childhood.
For obvious reasons.
So, and in fact, SB1 asked this committee to set what that reference with base pricing would be for so many of those. So I think there's some big pieces here, and even there's more questions than just the caps that we've discussed.
Talk about the benchmarks a little bit more. It's unclear. How's the benchmark being established and where is it directly coming?
It's coming from 350 large businesses across the United States, based on what they paid for those DRGs in 2024.
In Philadelphia and Wilmington?
Yeah, Philadelphia and Wilmington metropolitans.
Question.
I was curious whether we're able to break this data out based on a particular provider or providers within the state.
Yeah, I can bring it up.
Yeah, I'd like to see that.
I can compare.
Great.
Join us, Commissioner.
Just one quick question. On page 4, where the summary of findings, where it says based on emissions, allowed amount, and the median benchmark for each DRG, there's an excess of 51.8 million facility costs. So is that the same as like facility fees?
Yeah.
It's what's built on the facility. There's you get facility funds and your professional claims. So the facility claims, that's the facility claim part of it.
So, say for example, you have a procedure, one of our largest providers here in Delaware, but it's off-site, meaning that it's not at a hospital setting. And the facility fees are equal to or maybe more than it would be at the hospital. Do you consider that excess? That's what I'm trying to understand what excess.
This is no inpatient.
It's inpatient.
Yeah. So I'm not sure.
Well, I'm just curious about the facility fees, basically, is that is the same as facility costs is the same as facility fees?
I think it also underscores, this is Colleen Davis, it underscores the limitations of the information that's being provided because of the fact that we can't compare facilities, you can't compare specifics on some of the DRGs. So I think it's meant to just provide us with the summary baseline and somewhere to kind of go. I think it'd be interesting to see what data you can generate beyond this.
We can go by facility and we can go by procedure. So it gets a lot deeper.
Yeah.
That would be very helpful.
I think it's something that Mr. Overly brings up all the time.
Yeah.
To add to the commissioner's comment, this is Paul Wambach. I think the facility costs, you're not saying what their actual cost, you're saying what the state is paying the facility for these claims under these particular DRGs.
Right.
It's nothing to do with what their cost and profit or any of that kind of stuff. It's just what's being paid towards the claims.
I know, but it's excess of 51.
No, the excess just means we're paying 123.9. If we were paying all those at the average for the Philadelphia Wilmington area, we'd be paying 51.8 million less.
And this is Kyle Gay, and the facility cost, does that include, like, are there certain facilities that are going to charge the professional cost within the whole charge rather than folks who may have admitting procedure?
Yeah, I think
admitting
there's definitely
procedures, right? So there may be doctor's costs in the facility costs. But we don't know if that's half or 10%.
But that's part of the reason, using the DRG gets you at least a high level comparison.
Okay. That's all.
questions from committee members.
Could we have at the next meeting, just a follow-up of what our next step might be, and maybe asking one of the subcommittees in after July to look into this or that, but I mean, I love this, but I'm feeling frustrated that I may be getting charged up for something that's gonna go nowhere. So I'd love to know where we're going. And can we also have a pop-up for next summer, maybe September, October, to request if the random report is up, the updated one is out, if we can explore that at subcommittee meeting next fall?
I'll make that.
Thank you.
That moves us on to agenda item number 10, Senate Bill 1, Department of Insurance.
Okay, well, Trinidad Navarro here. I'll just give you just a pretty quick update since we last met. We, the department, had multiple meetings with Senator Townsend, very productive meetings. He has had a number of meetings with the Delaware Hospital Association. Listen, I'm not a legislator, right? So I understand the challenges of trying to get a bill across the finish line. So, you know, we're working on a compromise at this point, and again, I say we as collectively as a team, and I hope that we don't lose focus. That primary goal is to have an investment in primary care that we can solve it. It's not just a cost containment mechanism. But I will say that it's a big part of it. Brown University, I don't know if you all sat in that meeting, but they indicated that hospitals could survive on 170% of Medicare. And one of the speakers represented some of the providers made a comment that we would just break even. We're all nonprofit, right? So breaking even, or just doing a little bit better, having a 3 or 4% margin, I think is acceptable. I think that any for-profit company would love to have the asset to debt ratio that hospitals here in Delaware enjoy. So I just hope that we don't lose sight of the fact that we started this with the primary goal of keeping primary care docs solvent, and to at the same time lower costs across the board. So that's not really much of an update because there's not really anything new to discuss, but we're working on it and we're working on a compromise. And I just am hopeful that we'll be able to achieve our goal. But we all saw the emails, the phone calls, the Facebook posts, the comments about keeping politics out of your healthcare. I mean, there it is. And if we don't step up to the plate and do something about this, at the end of the day, the folks who they targeted in that mailer could have impacted the most, and they're the people in our state and our community.
For that update, we'll move on to agenda item number 11, public comment.
Statewide Benefits Office received 3 written public comments, which were distributed to the committee prior to today's meeting. If you are joining virtually and would like to make a public comment, please raise your hand at this time. If you are calling in by phone, please press #5 to raise your hand. This time I will ask if anybody in the room wants to make public comments. As I didn't have anybody pre-sign up, I will go. Hold on. Christina Bryan.
Thank you so much for the opportunity to comment. My name is Christina Bryan. I'm Vice President of External Affairs for the Delaware Healthcare Association. We are the association for Delaware's hospitals, health systems, and related healthcare organizations. Delaware hospitals are leading the way on addressing healthcare affordability. As you all know, we're now required to provide an unprecedented amount of transparency to the Hospital Cost Review Board and will be held accountable to the healthcare spending benchmark. We're the only sector of the healthcare system, not insurers or pharmaceutical companies or any others, that are going to be required to do this. I also do want to point out that DHA continues to have concerns with tying reimbursement to Medicare. Medicare pays significantly below the cost of care, so a 250% reference-based pricing cap that has been proposed would result in a $413 million cut to Delaware hospitals in the first year it's implemented. We also caution against comparing Delaware to other states, as Delaware ranks 5th oldest and 6th fastest growing as our fastest growing state in the nation, which impacts the volume of healthcare services utilized and costs. With that said, we are at the table. We're meeting with Senator Townsend, as the insurance commissioner mentioned. We're really hoping that we can come to a compromise on something that will address affordability and increase primary care investment, but doesn't result in a $413 million cut to hospital or health services in Delaware. Because there's such a growing need for healthcare services, we're really concerned about access and quality and want to make sure that we're able to continue to meet those needs in our state. Thank you.
Thank you. Is there anyone else that would like to make public comment? Please raise your hand at this time. Seeing none, I will pass it back to Director Maxwell.
That takes us to agenda item number 12, which is the approval of the dental benefit request for proposal RFP. We had discussed it previously. I think there was a comment from Mr. Baumbach about including some sort of language that would encourage the PRC to look at the contractual prices negotiated at final negotiation
With loss.
with the ratio.
But that wouldn't impact the actual RFP.
No, but I'm
document, yeah.
just putting it on the record that as we move this RFP process forward, that's a caveat that people want that part of this particular topic.
I'll move that we approve the RFP as presented to us.
A motion, is there a second? Seconded by Bill Early. Any discussion on the motion? Seeing none, I'll call for a roll call.
Director Maxwell,
Yes.
Secretary Gordon,
Yes.
Lieutenant Governor Davis. Senator Davis.
Yes.
Commissioner Navarro,
Yes.
Secretary Young,
You guys are cutting out, but I think that was me. Yes.
Deputy State Court Administrator Ashley Tucker,
Yes.
Yes.
Paul Bumbuck,
Yes.
Karen Peterson,
Not voting.
Bill.
Motion carries. Brings us to agenda item number 13, other business.
A request for the SDO for the next meeting. I've heard anecdotally, we passed a copay, additional copay for GLP-1s. We've heard anecdotally that copay assistance that was presented to us as a reason to be less concerned about that new burden on our participants would be available to them, but that when somebody tries to get that, it says, are you covered by a plan? And if you are, it's not available to you. If we could ask the SDO to please verify that copay assistance is indeed available to our participants, I would welcome that reporting back to us, unless you already know that.
Yes, it should be available. I think one issue has been that some people, I think, are checking off that they are in a government sponsored plan because they think that the state is that, but what that's really referencing is like Medicaid. So I think that might be some of the disconnects that people are checking that.
Is there communication perhaps I can go? So I would love to hear a month from now or our next meeting, what we're doing to help our participants know how to get effectively into that program.
Sure.
Thank you.
And this is Colleen Davis. You may have a lag in some of that data anyway because of the amount of, fill that individuals get, whether it's a 30 or 90-day supply. So you may want to make this an agenda item that kind of continually you report out on or something like that.
I appreciate it.
This, okay, just as a follow-up, I had emailed about making sure that the link to it is available in the open enrollment piece, because I saw the information about the copay. But it doesn't say underneath it, so I don't know where people would then find it.
Yeah, I sent you a follow-up, so
Thank
take a
you.
look and if.
Okay. But it might be helpful also to write in that, because like when anyone goes into open enrollment, there's a
Yeah.
big thing. And so maybe it says, note you are not in a government plan, like I will just do whatever to make it easier for people
Yeah.
to get that help. And Mr. Chairman, if I may, just one for new business, I note that a lot of times in our public comment questions where it's actually almost like a ask for help. And there's one in our written public comment now related to x-rays. And I just want to make sure, is SBO the constituent services lead on those requests? Or should it be something that some of the elected officials on this committee talk about as far as constituent
Yeah,
services?
let me look into that
Okay.
and see what what's happening with it, and then I can bring that back. If there's something that's more policy related, then it's.
Sometimes
that'd be
it's
a
just a
question
person
for you all,
needs help.
as opposed to like one individual person, we would help them. That's what's up, but I'll look into that one.
That's great. And I would just say, I don't speak for all the elected officials, but I know that all of us do constituent services in some manner. So I'm at least willing to be a partner if you need one.
Okay.
We've had a pretty rigorous last few months, but I know we had Christine Vogel scheduled to come in at some point, and that's gotten deferred, but I still would like to have that discussion around EPMs at some point in the future.
It's up to the Department of Charts.
Might that be a subcommittee?
I think it was, the intent was to inform the entire community
Gotcha. Perfect.
on that.
Mhm.
Any other business? Seeing none, brings us to agenda item number 14, adjournment. I'll entertain a motion to adjourn.
Second.
Motion for, who's in second, voice vote? Yeah,
Aye.
aye. Opposed? Cheers. All right, meeting adjourned. Thank you.
Well, in person.